Hi, I'm Jerry Tan from Windsor, Ontario in Canada, and I'm here to present to you rosacea treatment that is based on phenotypes. We know that rosacea presents with multiple clinical features from erythema to telangiectasias, thyma, ocular features, papules, pustules, and flushing. In 2002, the background is the subtype classification categorization was born. Subtype 1, erythematotelangiectatic, which included flushing and centrofacial erythema, possibly with telangiectasias, but not necessarily. Papulopustular. Subtype 2, centrofacial erythema with transient papules and pustules. And then subtype 3, phymatous, which is skin thickening, most commonly on the nose. And then ocular features, foreign body sensation, burning, stinging, dryness, itching. And what that led to was classification confusion by conflation. And what I mean by that is number one, patients present with clinical features. They don't present with categorical subtypes. Number two, these features can span multiple subtypes. Let's just look at facial erythema. Transient and persistent types can be part of subtype 1, subtype 2, subtype 3, and subtype 4, as can telangiectasias, as can phymatous changes, as can ocular manifestations. Why are we using this type of conflated categorization when we still don't have clarity on each of these features well enough to understand them and their pathogenesis? And remember, over time, patients can develop more and more features so they can progress between subtypes. And if you treat a patient, for example, with papules and pustules, and now they have controlled papules and pustules but have persistent erythema, are they now a controlled subtype 2 or are they a subtype 1? Which is why in 2016, when we convened a rosacea global consensus group, we came up with updated diagnostic criteria and categorization based on phenotype, not subtype. Diagnostic criteria where only one is required is persistent centrofacial erythema or phyma, either one. If you have any of those, either of those, then that's diagnosis of rosacea as long as you've excluded the other clinical features that can present that way. And dermatologists are uniquely trained to do that. Major features where any two are required include transient facial erythema, that would be flushing, inflammatory papules and pustules in the absence of comedones, and telangiectasias, as long as it's not perinasal telangiectasias, because those are so common in every adult I know. Ocular features, and the ones that are minor are not used for diagnosis, but they're important for tracking how the patient is doing because they might present with these features, but they're not specific enough. So remember, phenotype are the clinical features presenting in a patient, and this is now the basis of the phenotype approach of rosacea. So rosacea features diagnostic, any one, which is in red, major, any two, and that's how I would now rethink the presentations of the different clinical features, cutaneous clinical features of rosacea. Let's look at the facial features. Centrofacial erythema, thyma, you know those are diagnostic. Either one individually is diagnostic of rosacea. Centrofacial erythema, papules, pustules, very common type of presentation. By themselves, papules and pustules, as well as background erythema, when you have them together, those are major features. Two of them, they would be diagnostic of rosacea, as long as you've excluded other common etiologies of this type of presentation, like lupus, like seborrheic dermatitis, like sunburns, like photodermatitis of other types. So that's how I would conceptualize how we look at patients and then how we can diagnose and then establish their features that they're presenting with.